Can everyone see my screen?
Yep.
Okay. So thanks everyone for coming today. So this is the first of the Sense Education series, which stands for Synapse Centre for ESNAFT Neurodevelopment Education Series. The first session today is an update on perinatal development and mental health, and it's going to be one of four talks moving into July, which is hoping to capture kind of prenatal and perinatal development all the way through to transition. So in March we have an afternoon on preschool children, and then in May in medical comorbidities in children that impacting on learning and happiness, and in July there's going to be an afternoon session on transition into adult services. And in terms of an agenda today, we've got some really interesting speakers lined up. We have Dr. Regato from Baby Lab in Essex talking at 1:15, Dr. Annie Swanepoel, consultant psychiatrist at 2, on evolutionary perspective of perinatal mental health and neurodevelopment. And then from 3 to 4, we have Dr. Fowler and Professor Martin from ESNAFT talking about a research project they're involved in perinatal exercise. And then at 4 p.m, we have Dr. Hooper, who's a perinatal consultant psychiatrist, coming to talk. Unfortunately, Dr. Orty is sick today, has passed on her apologies. So what I thought at the start, I'd give a brief introduction to the Synapse Centre and the purpose of this education series. For those of you who don't know me, I'm a consultant paediatrician who works at Colchester. My main interest is in neurodevelopment. I set up the Synapse Centre in 2020, which is a translational centre trying to understand and impact on challenges for children with neurodevelopmental problems within our locality, focusing not only on behavioural issues, but also on health. And as part of our journey with the Synapse Centre, we're looking to collaborate with clinicians and researchers from all across the area to try and move forwards with our agenda. As part of my role, I also am children's lead for North East Essex and Suffolk ICB, and on a national level with the British Academy of Childhood Disability. So these afternoons are an opportunity for connecting researchers, clinicians, and wider members of the integrated care system, and an opportunity to learn from each other, to network, and to really importantly discuss future research opportunities and collaboration. And that's what I was hoping for this afternoon. If you have any ideas, if you hear anyone talking who you'd like to connect with, or from the discussions that are ongoing, then it will be useful to think whether a steering group in this particular area would be useful to start with a view to synthesizing and working on research projects on the groups of families that we see. At this point, I was hoping Annie would be here to give a brief intro to her role. Annie, are you here? So I don't think she is. In which case, I will give an opportunity to introduce Alex and Andrea, who have started today. So to give an example of how the Synapse Centre is hoping to promote research, but also clinical practice in areas of neurodevelopment, Alex and Andrea are newly assigned to 3-year posts, looking at research projects in preschool children and finding new ways to impact on their learning and development. So I'm really pleased that they're with us today. I think they're going to be joining us on at the meeting. But hopefully they're the start of many researchers that will come through Synapse Centre that we're hoping to have a real impact, clinical impact as well on the families that we serve in the community. But if you want to hear more about their roles or any of the other research through the Synapse Centre, please go to our website to find out more. So if I stop sharing my screen. Is Annie here yet? Annie Suarez? So Annie was hopefully going to join us to talk more about her role. Annie is a GP, but also is perinatal mental health lead for the wider ICB, and is passionate about education and collaboration, which is what this series is about. But I think in her absence at the moment, we might start with our first speaker. And maybe Annie can say a few words later on. So in terms of our first speaker, we have Sylvia Regato, who works in Baby Lab. She's a senior lecturer at the University of Essex, where she set up Essex Baby Lab for studying child development, and co-founded the multidisciplinary group From Womb to the World to bridge the gap between lab-based research and community of parents and professionals. Her research in developmental cognitive neuroscience focuses on how the infant's brain responds to social and perceptual stimuli, how these responses change over time, and how they're influenced by prenatal environment and postnatal experiences. So I will pass over to Sylvia now for the first talk. Sylvia, I don't know how long your talk's going to be, but hopefully there'll be some chance for discussion afterwards, but we're hoping to end this part of the talk by 2 o'clock.
Yeah, thanks, Ben. Thanks for the nice introduction and to inviting me to the first event of this series. I'm really pleased to be here. Okay, let's see. I'm starting sharing. Let me see. Give me a second. Can you see the
Yes.
first slide? Yes. Okay. Yep. Sorry, I'm used to Zoom for presentations. So okay. Hopefully, it will work. Okay. Okay. So the work I will be presenting today is a study we ran with pregnant women during the COVID pandemic. So that's why I'm here talking about prenatal mental health. This was an online study, obviously for reasons that we all know. Okay, so okay, let me just see, how do I go on? Oh, here we go. Okay. Right, so as we all remember, I think still very vividly, the emergency of the COVID-19 has led to a global health crisis, which has resulted in many changes, I think, that we're still adapting to. And we know that at the beginning, the focus was all about, obviously, mortality and then all the negative physical health outcomes associated with contracting the virus. And that was obviously in order to contain the spread of the virus. However, now research has been gaining more and more understanding also of the impact of COVID-19 on psychological outcomes. I would say that in particular, the implementation of physical and social distancing measures to slow down the spread of the virus have resulted in quite severe disruption to our lives. I think we all experienced possibly having children at home, so all the education environment, but also employment, healthcare, as you well know more than me, I guess, all the leisure activities, social events. So there were very new measures that were quite invasive, maybe in our life. So for all of this reason, we anticipated that implementation of these measures had a negative impact on mental health. And indeed, research shows that in times of natural disasters, so in this case pandemics, there is an increased risk in mental health issues, such as in post-traumatic stress disorder, but also depression and anxiety. However, what we know from research in the past is that natural disasters and their impact affect individuals differently. Specifically, gender inequalities and risk sensitivity lower the life expectancies of women more than that of men. And this gender gap effect in vulnerability to the consequences of natural disasters may be further intensified by the life-changing events, such as pregnancy. So this is what we'll be talking about. thus rendering pregnant women and group particularly vulnerable to the impact of disasters. And we know that pregnancy has been extensively shown to be times in a woman's life particularly prone to mental health issues, and among these disorders, the prevalence of depression and anxiety has been especially high. Is seen to be quite high during pregnancy, and you can see some percentages here in the slides. But what I think is quite key also to remember is that substantial percentages of mothers actually report subclinical perinatal symptoms, depressive symptoms that can go undetected by practitioners. And while maternal mental health difficulties that classify as subclinical have received little attention, one important notion that there are some evidence for is that these subclinical symptoms can already have impact on mothers and infants anyway, so significantly affect mothers and their babies. What some of the research is showing is that up to 40% of women experience subclinical perinatal depressive symptoms. And what is really important is that they have similar adverse long-term impacts as the more severe symptoms associated with clinical maternal depression. And this is not true only for mothers. Obviously, the longer a mother or a woman or an individual is feeling depressed, the worse this can be over time, but also has effect on their infants and their children later on. For example, I found in a study that there are cascading effects of maternal depression on infant negative affect. So basically, we found that how the mom was feeling the first few weeks after giving birth was actually affecting the infant's temperament in terms of negative affect at 4 months of age, and also how the mom was feeling at 4 months postpartum was actually predicting the temperament of the baby at 6 months. So there was this cascading effect, and there was also some association with conduct problems when their children were 3 years of age. And from previous literature, we also know that these effects can actually last with time also into adolescence and so on. However, we also know that maternal mental health difficulties can also have an immediate impact. So we don't have necessarily to look long term, but what we are focusing in this study here, it was the relationship with the fetus. So the interference of maternal mental health problems in the formation of a positive relationship with the unborn babies. And this is important because during pregnancy, the relationship between a mother and her child begins. And so it is really important to focus at the very beginning of this relationship. Okay, on a more positive news, I would say, there also exists evidence that factors from contextual domains, so for example, social supports, are related to maternal antenatal attachment. And in one particular study, they found that social support actually has a direct effect on maternal antenatal attachment, so that social support can promote maternal antenatal attachment, so this relationship between the mother and the fetus. And social support can also have a mediator role, so that maternal anxiety has a smaller impact on maternal antenatal attachment. So this is the good news of this bit. So in the work that I will be talking in the next few minutes, this work was done in collaboration with other colleagues in the Department of Psychology at the University of Essex, where I'm based, especially with Dr. Maria Laura Filippetti, who also works in the Baby Lab with me. The work is published in this journal, BMC, Pregnancy and Childbirth, and is open access in case you're interested to read the whole story. Okay, so what our research was about. So based on basically the literature that I just talked about, so the recent evidence showing that prenatal trauma heightens the risk of clinically significant antenatal mental health symptoms. What we hypothesized it was that direct experience of trauma due to the COVID-19 pandemic affected maternal antenatal attachment by amplifying vulnerability to mental health symptoms. Also, the recent evidence showing that higher social support is associated with lower mental health symptoms suggests that support may act as a protective factor. Okay, particularly for those who appraise the impact of COVID-19 to be more negative. So for this reason, what we anticipated was that social support may protect against the negative effects of this traumatic event by changing their appraisal. Okay, so as I said at the beginning, this was an online study, so it was an online survey, really. We managed to recruit 150 pregnant women through social media adverts. The surveys were all completed during the first and second lockdown here in the UK, so between April 2020 and January 2021. And on the table here, you can find the main characteristics of our participants. So in terms of age, they were about 31 years. All the education, they've been in education for about 16 years, predominantly white mothers, married or living with a partner. About, well, nearly 50% were at the third trimester, 40% in the second, and 12% in the first trimester. So there was a little bit of variety, with the majority being during the third trimester of pregnancy. I should also mention here, we also had an additional data set, actually, from some previous research before actually the COVID-19 pandemic, and we used that. I'm going to tell later a little bit more. We used that additional data set to compare the data from depressive symptoms during pregnancy. Okay, in terms of measures, we had different standardized questionnaires. So these are well-used questionnaires in our field. So one about depression, depressive symptoms, one about anxiety, the maternal antenatal attachment scale, the impact of event scale, the revised version, which basically we use to measure stress related to the psychological impact of the COVID-19 pandemic. And then we had specific questions in relation to the impact of COVID-19 on the relationships and lives of the participants. This item specifically referred to the current time period since the most recent UK lockdown started. So the question was, asking the participants to concentrate on this specific time they were living. The first time, which we called COVID-19 appraisal, asked the question here, so how badly do you think that you will be affected by the global effects of the COVID-19 pandemic? And there were some examples, and participants had to respond with options on a 5-point scale from not at all affected to severely affected. And then the last series of items related to the perceived social support during the pandemic. Specifically, there were these 3 questions. How well supported do you feel by your spouse or partner? And then the same with family and friends and the healthcare system. Again, participants had to rate the perceived support on a 5-point scale from I do not feel supported at all to extremely supported. Okay. So in terms of results, I will present in 3 different slides with these 3 headings here. So the prevalence of mental health symptoms, impact on mother-infant relationship, and the role of social support. Okay, obviously feel free to interrupt me if something is not clear or you want to ask a question. Okay, so in terms of prevalence of mental health symptoms, we found that pregnant women during the lockdown had higher depressive symptoms than women pregnant before the COVID-19 pandemic. And we could tell this because, as I mentioned a minute ago, we had this extra data set from about, I think it was similar sample of mothers before COVID. So we had used the same questionnaire about depression, and we could compare, and we found that these women during lockdown had higher symptoms than the one before the pandemic. So that was the first result. And also we found that the pandemic has affected prenatal mental health more broadly. So as you can see here, nearly 50% really of pregnant women reported mild to severe depressive symptoms. 60% reported symptoms associated with mild to severe anxiety, and 40% reported symptoms associated with the post-traumatic stress disorder as a consequence of COVID-19 pandemic. So, with this in mind, I think, we concluded really that there was actually a very specific COVID-19 negative effect on prenatal maternal mental well-being. So these are quite high percentages compared to what you see usually. And also what was quite striking when we were actually writing up the paper and reading more literature, we actually found that a study, when we were just publishing this, another study that looked at maternal postnatal mental health during the COVID-19 pandemic showed that 43% of women reported symptoms associated with depression, and 61% reported symptoms associated with anxiety. So it's quite striking to see the very similar high prevalence here, with 47 and 60% for depression and anxiety, respectively. Okay, in terms of impact on mother-infant relationship, our results show that expectant women for whom COVID-19 had a higher psychological impact were more likely to suffer from depressive symptoms. And also those with higher depressive symptoms reported feeling less attached to their fetus, to their unborn baby. Finally, what we found in terms of social support is that women who perceived the impact of COVID-19 to be more negative reported higher levels of anxiety, but not of depression, during the pregnancy. So social support, we found that social support was actually playing a protective role here, so as a protective factors in terms of mental health. So previous research, what we also said at the beginning, demonstrated that increased stress can actually heighten or worsen the symptoms of depression and anxiety during the perinatal period. And studies on psychosocial impact of COVID-19 pandemic have reported a surge in prenatal psychological distress among pregnant women. However, what we are seeing here is that increased social support from partner, family, friends, and the healthcare system were associated with lower anxiety, suggesting that social support may protect against the negative effects of traumatic events such as COVID-19. So there, as I mentioned at the beginning, the social support is really good news for even in difficult times as these ones that we just lived, and I don't know if we're still living on this. But yeah, all the restrictions imposed to control the transmission of the virus, to manage the impact of changes, also to the NHS service, have significant altered, for example, all the antenatal care of pregnant women. So it doesn't so, such as, for example, being unable to attend antenatal scans with a partner. That was, one of the measure that was there for quite some time during the lockdown, or even seeing routine face-to-face appointments with the midwives. I think they were replaced by telephone calls. So all of these modifications to the maternity service during the COVID-19 pandemic led to changes in the support net that is usually available to women throughout the pregnancy. So what our data is showing here is that the reduction in the perceived social support may have amplified anxiety symptoms, particularly for those women who appraise the impact of COVID-19 to be more negative. Okay, so as a summary of the key findings, we have that between 40 and 60% of expectant women reported symptoms of depression, anxiety, and post-traumatic stress disorder. As depressive symptoms increased, expectant women reported feeling less attached to their unborn baby. And women who perceived the impact of COVID-19 to be more negative reported higher levels of anxiety during their pregnancy. However, social support acted as a protective factor and was associated with lower anxiety. I think that all in all, we can conclude that there is the need, the necessity of prioritizing support for all pregnant women to protect their health and that of their infants, as well as their developmental outcomes. And this latest suggestion actually is also suggested by some data that we managed to collect from the same mothers when their babies were born. However, I have to say that the response rate was a bit lower, well, actually very low. So we had all about 30 mothers responding to these questionnaires. So we have to be careful in what we can infer from this data. However, I think they're still quite interesting in terms of practice and outcome for the mothers and the baby as well. In terms of measures, we used the same depression inventory and the anxiety questionnaire as well. We added a mother-to-infant bonding scale, a questionnaire about infant temperament, and a short assessment of patient satisfaction. So we didn't fully analyze the whole data, and as I said, the sample is quite small. However, what we found is that more than half of these women still reported mild or above depressive symptoms. Again, 52% reported moderate or high anxiety. And for the short assessment of patient satisfaction, we actually found that 77% of these women were dissatisfied or very dissatisfied. And in fact, they indicated that their healthcare has failed them in relation to their childbirth, and they were in need of help. So this kind of dissatisfaction was particularly apparent about explanations about their childbirth, so how it went in terms of respect, and the time spent with their doctor or the midwife. In terms of mother-infant relationship, we found that both depression and anxiety scores were associated with the bonding between obviously from the mother to the infant, even though anxiety seems to be driving this association. And in fact, what we saw in the data is that as anxiety symptoms increased, there was a drop in how likely new moms were to feel attached to their newborn baby. So again, we see how postnatally maternal mental health can impact on the relationship between the mother and the baby. Okay, so what we made out of all of this data here, actually there was I think it was last year a government call for evidence, and we advanced some policy recommendations. And I'm happy to share this with you. And so what we think it would be really important to start with is the promoting awareness of the prevalence of subclinical prenatal mental health symptoms through local health practitioners. And this, we think it's a really necessary first step to open up a conversation about the changes that are likely to occur during pregnancy, and also to reduce the stigma associated with mental health difficulties. Just as a reminder, all of these women who participated in the study here, but also in many other studies in the literatures, they are not clinically depressed or recognized by any practitioners that they are clinically depressed. So it's really data coming from the population, general population. Okay, what we think is that by encouraging effective communication, early detection of low mood and distress in expectant women will help identify problems as they occur, and timely interventions will prevent long-term negative impact on mothers and their babies. A second step may be that of targeting appraisal of prenatal trauma and social support as potential intervention strategies to protect pregnant women from experiencing short and long-term mental health issues, and as a consequence also developmental outcomes for their babies. We know that continuity of care from pregnancy to the postnatal period is associated with improved health outcomes for women and their babies, suggesting that public health practitioners are uniquely placed to fulfill many of the challenges that are also outlined in our research. So we believe that, given the pivotal role that they play in prevention, early identification and intervention for parents and their babies, it is really necessary to provide professionals with the appropriate tools and support to assess perinatal mental health difficulties throughout pregnancy, labor, birth, and the postnatal period. Okay. Oh, and there's one more. The evaluation of maternal mood and the bonding between mother and fetus, providing support to foster attachment relationships during pregnancy, where really is the birth also of the relationship between the mom and their child. So what it would be good to encourage is responsive caregiving practices since the beginning of pregnancies, by promoting awareness of the interaction between a mother and their unborn baby, and also awareness of these antenatal attachment relationships. So basically acknowledging that the baby in the womb is already able to learn, for example, from the environment, is responsive to maternal influences, is relevant for all, really, but maybe especially relevant for those parents who are displaying feelings of low mood. I think that's it, and maybe we can just finish with a call for a need for longitudinal studies. So tracking change over time, we think is really important to identify patterns of changes across development, and designing interventions aimed at helping individuals at risk from an early age, so from the very beginning of life. Okay, and that's it. So thank you.
Thanks, Sylvia. Great talk. So I'm going to open up for questions now, and then I'm going to introduce Annie Suarez, who's just joined us to talk about her role within the ICS. So in terms of any questions, you can either put them in the chat or put your hand up. We've had one comment already from Helen Bowles, saying that working in maternity systems, seeing a steep increase in referrals for pregnant women with anxiety and depression over the last few years, increasing by 300% in some places, and which is a significant amount. And I suppose, going what you were saying, Sylvia, on the environment for the unborn baby and the impact of stress, on hormone levels, but also on inflammation. And I'm hoping Dr. Swanepoel and maybe some of our other speakers might choose to reflect on the impact on inflammation, both from cytokines, but also autoantibodies potentially on risk factors for the unborn child with in the context of neurodevelopmental disorders such as autism and ADHD. And certainly with numbers increasing like we're seeing, we're also seeing a similar increase in numbers of autism and ADHD and other conditions. And whilst I'm not saying all autism is due to stress and other things, there's certainly a risk factor for maternal mental health and neurodevelopmental disorders. Any questions from anyone? Okay. So whilst maybe you're having a think about questions for Sylvia, I thought I'd introduce Annie. So Annie kindly helped me set up the program, and she is a GP partner at Ambrose Avenue Group Practice, an ICB perinatal mental health clinical lead. And I wondered if you have some time, Annie, to comment on your experiences in this area and what you've seen over the last number of years in practice.
Hello, everybody. Sorry for being a little bit late, Ben. Thank you so much, Sylvia. It's absolutely fascinating. I've had the privilege of you coming to our perinatal mental health meetings and discussing some of the work at the Baby Lab. Fascinating work that you do at the Baby Lab. I suppose as a GP, I'm not surprised that with the effects of the pandemic, because it has affected everybody, I think, across the country, lifting anxiety and affecting depression across a wide number of the population. And but as I've learned as a perinatal mental health lead and a GP spotlight lead, going out to practices, is the recognition of this effect on the development of the baby, of the fetus, and the stress hormones and the impact, and with epigenetics, the impact over generations. And that's a message that I've been trying to take out to primary care. I'm privileged to work with our North East Essex perinatal mental health steering groups and Suffolk steering groups, and my colleagues are far more experienced than I am in this area, but I can see that there's a huge increase in demand in the perinatal mental health services anyway, but particularly with COVID. So what you're describing in your study is out there in the real world. And as we've already highlighted in midwifery, 300%, my goodness, Helen, that's a huge amount. And I suppose the good thing is we're picking it up. We're asking the right questions. We're aware of it. We're more informed as professionals. And I think from a social aspect, something from your talk, it really highlighted to me the need for social support, the need for purpose, for network, for neighbourhood. And I spend my life as a GP talking about this, because it's not necessarily a medical need, it's a social need, it's a network, a family support, friends, groups, fellow mums, fellow antenatal mums, support. So I think that the aspect, certainly in primary care, of social prescribing and supporting people generally has become a huge topic, and this is highlighted in your study for women antenatally. And I think just from a general practice point of view, to highlight those people who, before they fall pregnant, pre-pregnancy counselling, pick up those patients who might be at risk, and to support them. I'm not sure how good we are in primary care at doing that, so I think that's a take-home message from me, actually, to think about those people before they fall pregnant. And just a big thank you to the perinatal teams and our midwifery teams for all of the work you do, because it's huge at the moment. So thank you.
Thanks, Annie. Catherine has just put a thing in the chat saying that some people can't unmute, which is unfortunate. But she's asked a question, Sylvia, thinking of antenatal attachment. I wonder if finding out the baby gender, etc., helps with attachment, i.e. picturing self with baby. Do you have any comments on that?
Yes, I think actually there might be some studies. I'm not too aware of those, to be honest, but in some occasions it might help, because it will allow, the new parents to, as she's saying, picturing, the self with the baby, but also imagining, how the baby can be. The thing is that sometimes we already start to attach, some temperamental characteristic to the unborn babies. When you see on the scan, if the baby is moving a lot and is, oh my God, it's going to be, hyperactive or whatever, or maybe they are shying, they are not making themselves, too available for the scan. So they might help, because you might start feeling already a relationship. At the same time, though, for some can be a source of anxiety as well. I think also independently from finding out, if things are going well or not, some parents might find quite, difficult maybe to realize that there is already a human being with all of these characteristics. So it's a yes and a no, I think, from me on this one. But there might be some evidence out there already.
Can I ask if you're following the families up? So are you following them up longer term, the women that you have already got as part of that program? Are you doing outcomes in terms of neurodevelopment? Are you following the children up?
Unfortunately, these ones were difficult, because already a few months later, when we asked the follow-up questions, we already had a low rate of response. And I think mainly because it was all online. When we do longitudinal studies in the lab, then it's easier, because you actually start a relationship with them. In the lab, you see them in person, and they are quite keen to come out with a baby and come back and so on. So longitudinal studies, we love to do in that, but they are more successful when you can do it in person, at least in my experience.
Okay. Frances, you have your hand up.
Yes, hi there. My name's Frances. Good afternoon, everyone. Thank you, Sylvia, for that lovely, very interesting presentation. I am a perinatal mental health midwife in Essex, and at Southend Hospital. I have been for 12 years now, and during that time I've worked with women all across the scale, and families, from women with mild to moderate symptoms right through to women with very severe conditions. And whilst I would never want to challenge anything that's within your study, it's just expanding upon the fact that support, it would also come down to the quality and style of that support, because I've worked with many women who've got wide networks. They've got parents who are very included, they've got partners who are often described, I'm sorry there's a stereotype here, but as really lovely guy but doesn't really get mental health, and therefore it's quite good at running the hoover around and giving me lifts, but won't talk to me about how I'm feeling. So in terms of the support, it was really just a comment that it's what that support actually looks like and means for women, whether or not they would recognise it as being support. And also there's just going to be the kind of the gloomy aspect, which I can't help but think when I hear these presentations, because we need so much more in perinatal, so much more. And even before the pandemic, I've watched antenatal education get stripped away, and that network of people in your community that you would have a cup of tea with, and then you'd see them walking down the high street and go, oh, hi, that's gone. It was huge, big centres where you would sit in front of a PowerPoint presentation for 2 hours learning about pain relief, on an uncomfortable chair in a primary school. And there was no opportunity really to build a network there with people who are at the same juncture of their parenting kind of journey. So that was already happening before the pandemic. And yeah, really just to kind of mirror everything that you have said, I've watched it happen the anxiety, as you know, as I'm sure have other professionals who are working in this area, it was just through the roof. Text messages all of the time. I'm a caseload midwife, so these are my women, and I'm worried about this, and I'm worried about this, and I'm worried about this all of the time. And it was happening anyway with the stripping of the resources. And then when the pandemic hit, it went absolutely through the roof. And I can see why the attachment is affected. Even myself as a parent, when I am stressed, when I am overloaded, I haven't got time for them. My kids are annoying, you know. So in terms of being able to build that attachment and think about how you're going to be there all of the time, just in a really basic level, I could see why that would happen. And yeah, just to verify that on ground level it is happening and women are really struggling. So that's my little speech there, but thank you for your presentation. And yes, it's all true.
Yeah, well, thanks for your comments. I think are really valuable, because you know it's really a testimony of what's happening, as you say, also what was happening even before, you know, the period that we've been living, and how these things has been exacerbated by, you know, all the difficulties. And it's all obviously, you know, we talked in this study about, you know, how expectant mothers live that, but as you say, like, you know, midwives and all the professional services were affected themselves, because, you know, most of the time they have a family as well, and everything was happening to every individual. So, you know, I was teaching at home with, you know, I think I was pregnant about then, with other 2 kids at home, you know, and they were appearing, coming and going when I was teaching, and it was crazy for everybody. And the other thing, it was about the social support. As you said, it is about how it is perceived. And in this study, we actually asked the perceived support, how they were feeling supported. And the quality, not the quantity, as you said, right? So, you know, how important it is that the person there is, you know, is giving you the presence, or, you know, the listening ear that you need, and the emotional support that you need. And it's not easy. And we know, you know, you well know that in the past years, also the family structure, it was much more different from now. I mean, you know, my family lives, my husband's family as well, they live in Italy. So, you know, we were here, while, you know, years ago it was all the family living together, or I don't know, the mother was living with her own mother for sometimes. In some countries, still like this. So when you know, I think at the end of pregnancy, the wife will go and live with her mother, and you know, with no husband or partner, and feeling supported in a way that maybe only other people who went through pregnancy know. Who knows? So the family structures are changed, and, you know, for some things it might be better, but other things, you know, we know that it's been and it's a struggle. It's a struggle for new families.
Thanks, Francis, for your question. I think I interrupted Catherine Fowler. Apologies, Catherine. Did you have a question?
Wait, let me unmute now. Oh, sorry, it's let me unmute now. No, I don't think so anymore. No, it's fine. I just wanted to say Sylvia's presentation was really good. So
apologies.
No, it's fine.
I had a question regarding the group that you interviewed. Did you get like priority targets for what they would perceive to be good support? What ideas they had, which may have made their experience of pregnancy better from an actual practical perspective?
In what we asked, you mean? In
terms of asking what would have improved.
No, we didn't preempt anything in those questions. It was just the questions where they were saying, you know, how well they were feeling supported by their partner or whatever, I suppose, the family and friends, and the healthcare system. Then they only had to rate between 1 and 5, from not at all to extremely supported or something.
But in terms of moving forwards, in terms of acknowledging the stress that exists, asking them what in their opinion would make their stress improve, what would they prioritize as key things that would help them?
Yeah, I don't know. I mean, it would be really interesting to find out, to be honest, and see, you know, what comes out. Maybe a focus group, or, you know, some kind of these research measures will be really interesting, so that it will help direct more all of our work, I think, either to include more family members into prenatal visits, appointments, and starting from GPs. I think it's still the case now that when you're pregnant, you first say to your GP, and then from there it's all the referral. So already there, maybe making sure that the partner or whoever family member is there can be involved.
Because I think that would be the next step, is, as you said, it's having a group that looks at priority setting about how, because as Francis rightly said, everyone's idea of mental health is different, and what supports one person won't support another. But having a strategy moving forwards to, I'm sure someone has done this already. So I don't know if anyone else has any other comments about that. No, okay. Francis, you still have your hand up.
I just put it back up actually, because whilst I don't do a study on, I haven't done a study on this, but the kind of feedback that I would get is that women would like more time, and that was kind of implied within your study with regards to respect. And I wonder if they're overlapping, a feeling of having time to ask the questions that you would like to ask. And it may be that those questions were dismissed really rudely and they weren't given clear answers, but I also think that there's incredible amounts of time pressures for health professionals, and it may be that questions are shut down as a strategic way of coping for the health professional, because they'd love to sit there for half an hour or an hour with each family and say, if this thing happens in your birth, or if this thing happens after the baby comes, this is what we would recommend. And obviously we all know that there just isn't the luxury of that time. So what I would see as something that women would seem to be coming to me and asking for is more time, more personalised care, more face-to-face interactions, so that they can ask and get the information, get the questions that they're asking. And again, sorry, I know I'm going on, but that's something that is missing, because when women and families, couples were seen in groups for antenatal education, you would get that capture, because somebody would ask the question that you wanted to ask, but you were shy, or you hadn't thought that you wanted to ask that question, but now you want the answer, and you'd get everybody all at once. And that's missing. I think when things are online, a lot of people are apprehensive about putting their hand up and speaking to people on a screen.
Okay, yeah, very good point. Many thanks. So I think we'll probably wrap up Sylvia's session. If there are no other questions, last chance for anyone? No? In which case we'll probably move on. Many thanks, Sylvia. And I'm sure someone asked to have access to your slides. Would it be okay to share those with me? And then I can put them on our website.
Yeah, definitely. I also put the link to the paper in the chat as well. Someone was asking, and I'll send you the slides. No worries. Yeah.
Fab.
Thank you.
Okay, great. So our next talk is Dr. Annie Swanepoel. Are you here, Annie?
Yes.
Great. So things are working well. So we're running to time, which is good. So I'll just go down to your talk. So Dr. Swanepoel's talk is on an evolutionary perspective on perinatal mental health and neurodevelopment. Dr. Swanepoel is a consultant child and adolescent psychiatrist who works in SETCAM's learning disability team across Essex. She also holds a PhD in human physiology and has a particular interest in evolution, neurodevelopmental disorders, and developmental trauma. So over to you, Annie. I'll mute myself, but if there's any issues, I'll just ask me a question, okay?
Okay, well, thank you very much for inviting me, Ben. And let me try and share my screen. So if you could just let me know when you see it.
Yep, can see your screen.
Okay. I always find this part the most stressful. As soon as I've got the slides up, then it becomes easy. Okay, can you see the full screen now?
Yes, that's all great. Thank you very much.
Good. So The Royal College of Psychiatrists has a perinatal part of it, and they brought out this report in September 2021. And I just want to read it through because this is really well understood. And that is that pregnancy and the first few months and years of a child's life are critical for brain development, laying the foundation for future learning, behavior, and health. The mechanisms underlying these associations are complex, and they include a range of genetic, other biological, and environmental pathways. The chronicity of exposure is important, and co-occurring environmental risks and other adverse childhood events are also known to impact. And I think that is also what our previous speaker spoke about. For example, through exposure to co-occurring parental conflict or pandemics. Around 3/4 of the high economic cost of perinatal mental disorders are attributable to long-term adverse effects on children. And we know that prenatal exposures, whichever they are, so those are a few listed, lead to changes in the pre and perinatal molecular processes. So that includes neuroinflammation, as you mentioned, Ben, and epigenetic programming. And that can then lead to postnatal outcomes for the child. And we see a lot of children like that. So Tinbergen is a scientist who said that if we want to understand anything in biology, we should be asking 4 questions. How does it work? What is the mechanism of it? And I think we're generally very good at that. A lot of research is around how does it work? What are the neurotransmitters? Which inflammatory markers? What does it look like on a brain scan? Then the second question he says we need to focus on, and again, this is regarding anything in biology, is how did it develop? What's the developmental process? And that I think we are getting better at. There's a lot more understanding that there are cascades of development and that things happen slowly and can have long-term impacts. And one of the reasons I chose child psychiatry is really because it's recognized that 3/4 of all mental illnesses start in childhood. So you have to really look at the early side of things. But then what we are generally not good at is asking the third question. How is this behavior adaptive? Is there any survival value to the behavior? And how has it evolved? So evolution, looking at it across species. And I really agree with Durbansky, who said nothing in biology makes sense except in the light of evolution. And I've read up a lot about evolution, and a key insight for me is, you know how you've probably all heard about survival of the fittest, but that actually refers to the survival of those individuals that fit best in their environment. So those that are adapted to their environment. It's not really about the fittest in terms of the strongest or fastest. It's around the goodness of fit between the individual and their environment. And that is a really key concept. It's not about strength or intelligence, but about adaptation. So that's why we have things like snails and slugs and tortoises and sloths. It's not about being fit as people understand it, but to fit in the environment and the match between the individual and the environment. So my talk is really taking a broad evolutionary view on how babies are primed to adapt to their environment, both before and after birth. That's what I want to talk about, just to think about it, because that's taking it from a completely different point of view, looking at, is there an adaptive value? And I want to refer to these 6 concepts, which I just want to go through just to give you a whistle-stop tour. Intrauterine programming, parent-offspring conflict, attachment theory, differential susceptibility, life history theory, and evolutionary mismatch. And first of all, I want to talk about intrauterine programming. So we know that the baby, the fetus intrauterine, is exposed to the maternal circulation through the placenta, and that includes being exposed to hormones, it includes being exposed to inflammatory markers, and that has a big impact on how the baby develops. So I'm not going to go into the detail of that. I don't think anybody really understands all of it, and there's a lot of research. But what we know is there's definitely a big impact. The baby is being primed while in the uterus for the environment it is likely to encounter. So fetal programming prepares the infant for the type of postnatal environment it's likely to encounter. Dangerous environments lead to a fearful mother who is less able to provide sensitive care, and early experience calibrate the stress axes to shape fear reactivity, resulting in young who are hypervigilant and fearful, and that is adaptive in a dangerous environment. And I think that was a really important key insight for me, because we know that, like in the previous talk, we heard that women who were in lockdown during a pandemic were more anxious and stressed, understandably so. I think non-pregnant women and men felt exactly the same way. And that was a reasonable response to a threat that was potentially to life. And these babies were exposed to their mother's hormones and their mother's whole bodily state of being anxious, and that then makes the babies more fearful, so that they are then, in theory, more adapted to a dangerous environment once they're born. That's the theory. And Professor Vivek Glover is a real expert on this, and she's written a lot about it. So she said stressful life events, exposure to a natural disaster, and symptoms of maternal anxiety and depression increase the risk for the child having a range of emotional, behavioral, and cognitive problems in later life. So that we know, that's also recognized. Brain imaging research reports that maternal stress is associated with changes in limbic and frontotemporal networks and the functional and microstructural connections linking them in the baby. So is there an adaptive value? So she continues to say that in our evolutionary history, it is possible that some increase in these characteristics in some individuals was adaptive in a stressful environment. So you can think that amongst hunter-gatherers, anxiety may have been associated with increased vigilance. And if you were more vigilant, you might have been quicker to pick up dangers and escape them and live to reproduce. And so this tendency is then also passed on to offspring. So distractible attention, like you can get in ADHD, might mean that if you're not so focused on one thing, let's say you are trying to find berries in a bush, and you're more easily distracted, you might notice a snake coming towards you. Impulsivity might lead to more exploration, and there's certainly some evidence amongst the Arial tribe in Kenya, where those who have got the DRD4 variant and tend to be more impulsive, more looking for greener pastures, were better fed in times where it was difficult for them to find enough food. So if you tend to being more happy to take risks, that might lead you towards better situations. Conduct disorder, sometimes you might need a willingness to break rules. And aggression, it might be a very important thing to help you fight intruders or predators. So a lot of the things we tend to think of as purely pathological may not have been purely pathological in our past, in our evolutionary past, and perhaps even not today. Also, something Vivek Glover has written about is the sex differences. So we know that prenatal stress increases anxiety, depression, and stress responses in the girls, the females that are born. And in stressful environments, it might be adaptive for girls who then grow up and are likely to have their own children and stay in one place to be more vigilant and therefore be more responsive to stress. On the other hand, boys are more likely to show learning and memory deficits if they've been exposed to prenatal anxiety in the womb. And when they grow up, it may be adaptive for them to go out, explore new environments, compete with other males, be more aggressive. And for this, it may help to be less responsive to external stresses compared to women. So in psychiatry, we often say women are more inclined to be internalizing and men externalizing. Of course, you get lots of exceptions, so these are just general rules. So the second thing I want to talk about is parent-offspring conflict. Data gathered from anthropological fieldwork shows that maternal love did not evolve to be unconditional and inevitable. So as much as we would like to believe that, that is not the case. Mothering has evolved to be sensitive to contextual factors, and the cultural presumption that women evolved to love their infants automatically, selflessly, and whatever the circumstances is incorrect. And that was quite a hard thing for me to learn and realize. Because we know that mothers had to make difficult choices when resources were scarce. There may be a conflict between what is best for the child and what is best for the mother and her other or future offspring. So we know that amongst hunter-gatherers, if a baby was born while an older sibling was still breastfeeding, and in hunter-gatherers, they often breastfeed until the older one is 3 or 4 years old. If a baby is then born and the mother won't have enough milk to be able to provide for both, the newborn would be left and not raised, not supported. So a baby whose mother was not committed to their care was in life-threatening danger for the most of our evolutionary history, because mothers could not always bring up all their children to survive. There just wasn't enough resource to go around. Now, hang on, I'll have to come out of this. Sorry, it's refused to let me. Ben, can you hear me?
Yes.
I can't seem to move to the next slide. Can you see the next slide now?
You stopped sharing the screen.
Okay, sorry about that. Let me just see if I can get back to it. It's happened once before that in the middle it just suddenly stops and won't let me share, won't let me go ahead. Can you see my screen?
Not yet.
Now?
Now, yes. I can see parent-offspring conflict.
Okay. So in our evolutionary past, between 30 and 60% of children typically died before adulthood. So that is a really scary number. And in such societies, a mother had to calibrate her response to her infant in relation to available resources, the needs of any older children, the strengths and vulnerabilities of the new infant. Maternal responses to their infants may lie anywhere on a spectrum from close bonding to ambivalence to abandonment. Because for the mother, it depends on whether she is able to take a particular newborn through what it will need to grow up. And we are the descendants of those mothers who did whatever it took to leave some surviving children And that brings me to attachment theory. So nature does not prepare babies only for the optimum, where they are loved and wanted. And babies have some degree of influence over their survival via their own behavior influencing their caregivers. Now, I'm not saying this is a great deal of influence, it's just a little bit of influence. And babies develop different attachment styles to mothers that are warm, rejecting, ambivalent, or abusive. And please note that those who did not develop an attachment and elicit care did not survive, and their genes do not persist in the gene pool. So if we think of mothers who have enough physical and emotional resources, it's like we spoke about earlier. If you've got enough social support, if you've got enough of everything you need to look after a child, it's much easier to provide sensitive and responsive care. And these babies develop a secure attachment where they have high levels of trust. And this is adaptive in a benign environment. But, and I think again, this is something which is generally not recognized, this is not adaptive in a harsh environment. So if you grow up to where everybody's nice to you and you've got everything you need, and you think the whole world works like that, you are probably at high risk of being exploited if you are in a dangerous environment. Now, thinking about mothers who might have other children, who might be stressed, who might not have support, and who find it more difficult to give care to a particular infant, who might be a bit more rejecting, those babies learn to become as independent as possible in order not to antagonize a dismissive mother. And these children develop an avoidant attachment, and that is called or described as being compulsively self-reliant. And these kids do not show their stress. So I think of an avoidant attachment like a Clint Eastwood cowboy, completely self-reliant, doesn't need anybody. And it's important to recognize that it is adaptive not to expect support if none is forthcoming. So for these babies, if they have mothers who don't have much time or resources for them, and nothing they do is going to change that, their best strategy is not to expect it and to become as self-reliant as possible as they get older. On the other hand, if you have mothers who are preoccupied and inconsistent, who can give good care, but who may not be thinking of the baby at all times because they have other things which are distracting them, these children might develop an anxious ambivalent attachment style, and they may become what we call compulsively care-seeking. So they become clingy and whining. But once again, this is not pathological because it allows the children to get the most care possible from a caregiver who's able to provide good care when given lots of prompts by crying, whining, and clinging. So these kids, by upping their distress signals, are getting the care they need. And in that sense is again adaptive. Now, the fourth category, the disorganized category, is very prevalent in psychiatric patients. So about 90% of psychiatric patients fall in this attachment category. And it's associated with care by a fearful or frightening caregiver whose own childhood is unresolved. Sarah Hurdy has previously argued that these children would not have survived such adversity, and therefore we can't think about it as an adaptation. It's a disorder. It's not something which has helped children. But Hultigan has argued that freezing, because what these children do is when their caregiver, when they've been separated from their caregiver and the caregiver comes again, they freeze. And he said it might be a functional response, which allows a protective role in high-risk contexts in which caregiver behavior may be potentially harmful. So again, it might be that if you have a caregiver who is dangerous, who hurts you, freezing might be the best thing you can do in order to not get on their nerves. And in 2021, a whole group of attachment researchers across the world came together to provide this consensus statement. Unless the world is successfully engineered to become a responsive and safe place with plenty of resources for all of its inhabitants, it may not be justified to consider only secure attachment relationships to be adaptive for all individuals. And I think this is quite important because a lot of what we think about in psychiatry, of what we see as being abnormal or pathological, may not be so. It may be completely adaptive. And the same is true in pediatrics and perinatal mental health. I just want to mention differential susceptibility because we know that some children seem to be incredibly resilient. So all children show a degree of adaptability. Some are more sensitive to environmental effects, whether these are good or bad, than others. And this is called a differential susceptibility and not a vulnerability. So previously people thought all children are resilient, the ones who are not are vulnerable. But we now realize that that is not the case. Children differ in their ability to be resilient. And really, the ones who are resilient are less sensitive to the environment. And there are certain genes which have been linked with resilience, like the serotonin transporter and dopamine receptor genes. So just to explain this a bit more, when they talk about differential susceptibility or developmental plasticity, people use the examples of dandelion and orchid. So the resilient children are like dandelions. They grow wherever, they thrive, they do well, whether they get good care or not. In contrast, the children who are sensitive to the environment are more like orchids. They need to get really good care in order to flourish. And when they don't get really good care, they struggle and they really have a lot of trouble. But when they do get really good care, they outperform the dandelions. And that is why it's not a vulnerability, it's just a difference. So that in nature, what it means is that if the situation is difficult, if the environments are harsh, the resilient dandelions do better. Whereas in good environments where there's plenty to go around, you then get the sensitive orchid children outperforming the resilient ones because they do particularly good, well when the environment is good. And in mental health services, we don't really see the resilient children because they sail through. We're much more likely to see the sensitive children who suffer when their environment is tough. And the positive about that is that these children can do extremely well if the environment is changed for the better. Because remember, I spoke earlier about the goodness of fit between the individual and the environment. And these children are very sensitive to the environment. So that makes it really important for us to consider it rather than just focusing on what's wrong with an individual child. It's around how can we adapt their environment so that they can have a better fit. And this brings me to life history theory. This is also a concept in evolutionary thinking, which I think is very important for perinatal mental health. So there are a series of unconscious decisions that an individual has to make. When to start reproducing, how far apart to have children, how many of them to have to nurture. And the question really from an evolutionary point of view is, will an individual leave more surviving children if they wait before starting to reproduce? Or will there be a too great a risk of being eaten or killed before having any children? So should they start reproducing straight away? And I'm in no way saying that this is a conscious decision or should be a conscious decision. This is just an explanation of how things work across different species. So elephants, for example, have a slow life history. They defer reproduction. They tend to have fewer offspring in whom they invest considerable resources. So the focus is on quality. And that is adaptive in a benign environment. And that, I think, is again important, because that links back to what I said previously about a secure attachment. If the environment is good, if the young one is safe and gets good care, it absolutely makes sense to invest in quality, because you're not scared that the child is going to die. And the focus is then on giving the best possible care to the few children who are there, or the few young ones who are there. So it might be easier to understand this if we contrast it with fast life history. So rabbits, for example, follow a fast life history. They begin reproducing at a young age. They tend to have lots and lots of young ones, each of whom gets relatively little nurturance. So the focus is on quantity. And again, this is adaptive, because rabbits are many different predators, including foxes and owls and all sorts. So when rabbits, if we imagine, if a rabbit mother only had 1 or 2 little ones, chances are they would be eaten and they wouldn't grow up. So from an evolutionary point of view, rabbits have lots and lots of young ones. And then what happens is, in spite of many of them being killed and eaten, there are some who survive. So the focus on quantity is adaptive in a harsh and dangerous environment where many young ones are expected to die. So just to summarize that, in a dangerous world, an insecure attachment and a fast life history is more adaptive in terms of survival and reproduction, even if it does create genuine suffering, because evolution does not select for happiness. It's only about survival and reproduction. A secure attachment with a slow life history is more adaptive in a benign environment. So, thinking about the unborn fetus who's being bathed in all the maternal stress hormones and immune modulators, this baby is being prepared for the environment it is likely to encounter, because the mother is already in that environment. The mother's endocrinology, the autonomic nervous system, the immune system is reflecting the environment the mother is already in. And the unborn baby is being primed to that environment through the mother's communication through the placenta of all these chemical substances. So if we think about how this then works in terms of life history, if the mother is in a harsh environment, the child will have a disrupted neurodevelopment, is more likely to suffer adverse childhood experiences, more likely to have social, emotional, cognitive impairment, adopt health risk behaviors like teenage pregnancy, going into a fast life cycle. You get more disease, disability, social problems, and early death. So the implications are, the more adverse the early experiences a child has, the greater the likelihood of a faster life course, so the life history, with more stress, more physical and mental illness, less stable relationships, and a shorter life. And this is the intergenerational transmission of trauma. So that's where you get it generation after generation. Natural selection acts on survival and reproduction only. Therefore, as long as affected individuals continue to survive and reproduce, the intergenerational transmission of trauma will continue. Evolution does not select for happiness. And then the last concept I want to talk about briefly is that of evolutionary mismatch. So an evolutionary mismatch occurs when the environment in which an organism lives is significantly different from that in which it evolved. So that traits that were once adaptive may become pathological. So if we think just of food, in our evolutionary history with hunter-gatherers, food was often scarce, and we are the descendants of those ancestors who were good at making the best of the few calories they got, and who, when there was extra food, if there was a successful hunt, ate to their full, and who sought high-calorie food, because those people then had extra fat resources so that if the next famine came, they survived. Now, this trait, which helped us survive for hundreds of thousands of years, is now a problem because the environment has changed. So in our environment now, high-calorie food is plentiful. And our adaptation of wanting to eat high-calorie food is now causing a widespread obesity epidemic. So this is an example of where the way the individual is, where it doesn't fit the environment. The environment has changed significantly. And I've previously also spoken about ADHD as an evolutionary mismatch. So I just wanted to mention it here for those who are interested, because there is information around this. Just thinking about children with ADHD who have lots of energy, who are willing to explore, who take risks, how that may have been a good thing in the past and not have been a problem. But in our current schooling, where we are expecting children to sit still, becomes a problem because there's the strengths of the individual with ADHD do not fit the environment of our modern schools. So to conclude, the investment that a mother makes in her child is on a spectrum from indulgent care to ambivalence to rejection. The mother's, and I say mother, but of course this is true for a father or a caregiver, anybody. It's not just applicable to mothers, but the mother's input in the child is dependent on the emotional and physical resources that are available to her. And that, I think, is really important, because if we want mothers to provide more input and better care to their children, we need to improve the emotional and physical resources that are available to the mother. If resources are limited, there's a trade-off between what is best for the mother and what is best for the child. And that is something I've previously written about with some of my colleagues around child abuse, how to understand why mothers abuse children. Is when resources are limited, a mother may make a decision which is best for her and not what's best for the child. A mother's stress level, which is a direct result from her environment, so the external environment or her perception of that in terms of her internal environment, is transmitted to the baby through intrauterine programming, thus preparing the baby for the level of stress it is likely to encounter once born. Because if the mother is in an environment which is causing her to be stressed, chances are that environment will also be stressful for the baby if it's a dangerous or harsh environment. Babies have adapted to respond to the quality of care they receive, as illustrated through attachment theory. So secure attachment with a slow life history is adaptive in a benign environment. And I think we need to be really careful, because I think many of us working in this field tend to think that a secure attachment with good quality, responsive, sensitive care, lots of resources, isn't just adaptive in a benign environment. I think we think that is normal and anything else is pathological. And I think we need to be careful of that, because in a dangerous world, the pathway described by insecure attachment, predisposing to fast life history, is more adaptive in terms of survival and reproduction, even if it does create genuine suffering. And that is a really hard-hitting thing. I think when I first understood it, I was really, and still am, really struck by it, because it does create genuine suffering, but that is what works. If you think about rabbits, they have lots and lots of little ones, of whom only a fraction survive. However, there is a differential susceptibility in which not all babies are equally sensitive to environmental stimuli, and some are more sensitive than others, giving an advantage in good and harsh environments respectively. So again, this is something where in the past we used to think resilient children are normal and other children who are not as resilient are vulnerable or pathological. And understanding more about the spectrum of evolution and our genes, it is really helpful to understand that those individuals who are more sensitive can do exceptionally well in the right environment. And there's an onus on us who work with children and schools to bring that forward and to explain that, to not only think about the child being abnormal in whatever way, but to rather think about the goodness of fit between the child and their environment. And I've based the talk that I've given on 2 chapters that I've written with colleagues in this book, Evolutionary Psychiatry, which came out in 2021, and those publications, which also include the references. So thank you very much.
Great talk. Many thanks, Annie. And I've heard that talk before, but it's such a great and powerful presentation. Any questions from anyone? You can either put your hands up or put it in the chat. So Sylvia, you have your hand up.
Yes, hi. Well, thank you. It was a really, really interesting talk, really insightful. And I don't know, my question is, I think, linked to the evolutionary mismatch. And I was thinking whether you think what's actually happened in COVID time, so that babies in the womb were raised by mothers maybe with, not maybe, but we know with higher anxiety and depression level. And then maybe when the baby was born, the environment was, again, sort of a baseline, or, a little bit better than what expected. Do you think it's one of these examples that can fit the evolutionary mismatch you mentioned?
Yes, I do think so. I think that is something we see. So COVID and the pandemic was a good example now, but we've previously seen that, for example, with children who've suffered abuse and neglect with their birth family, and then they're adopted into a different family where they're getting sensitive and responsive care, but the child cannot make use of it because the child is still has the worldview of people being out to get you and you can't trust anyone. And that in a way is also a mismatch, because the situation the child was primed to expect and had in the first bit before they were adopted is not what happens afterwards. The child's environment has changed dramatically, in this case from bad to good, but it still creates a problem for the child because the child then is not adapted to the situation they find themselves in. So that, yes, regarding the pandemic, for sure, we would hope that these babies, even if they are more anxious initially, do learn that the world is safe and there isn't always a pandemic and there's lots of things which can help.
Thank you. That's really interesting.
Some very positive feedback, Annie, for you in the chat from Bonnie, Lee, Leah and Annie, saying it's a very fascinating talk. Any other questions from anyone? I think from a clinical perspective, we are seeing a large cohort of children coming through who do have these superpowers. So they're the bunny rabbits you describe. So born with hypersensitive to hearing, to all the senses. which are very hard to manage as a parent, but also as an educator. So they're in environments in preschool where they can't learn because they try and gate the world out because they're overwhelmed. And I think as part of our project we're doing through Sprites, which is Andrea and Alex, we're trying to put interventions in staff training into preschool, looking at sensory differences and managing sensory issues and for children to self-regulate. But far better would be to have more of an impact prenatally, where things would be a lot easier. So if you stop the in utero imprinting from happening, this stress response which leads to this big immune cascade, you'd have a far better outcome. I think.
Yes.
I think like anything in health, the earlier you impact, the better. But for some reason within the NHS, we leave things to that things get really bad. But the whole idea of health is to be preemptive, and that especially for in this area.
I was when I listened to Sylvie's talk, I thought I should have put something else in my talk, and that is around social support for pregnant women. I work with an anthropologist who's done field work with the pygmies in Africa, and he has done a study which we are publishing now, which is around support for pregnant women, and also once the baby is born. And in hunter-gatherer communities, these are typically communities of a few families, so perhaps 100 or 150 individuals. And then once the baby is born, he tracked who responded to the baby when the baby cried. And across hunter-gatherer situations, 50%, a good half of babies' cries are responded to by alloparents, so not the mother, usually other females or even children in the group, so that mothers are then far less, or they're not overwhelmed, because there's always somebody else who can help. They're never on their own with a crying baby. And that, I think, will make a huge, huge difference. Is just if it's possible to try and recreate more support to mothers with young babies, and even in pregnancy, that will reduce a lot of stress.
Annie, you have your hand up.
Just thank you so much, Annie. Gosh, that was quite mind-blowing. I'm fascinated by what you presented. I mean, Ben knows I'm interested in lifestyle medicine, in functional medicine, so root cause. So the NHS is way behind, really. One day in the future, we might really start, or even now start with looking at things very differently instead of patching things. And of course, in general practice, we're ace patchers. We don't get to the root of things. But what you've described is fascinating. I mean, it's again, Ben, what we've talked about is that education. So we've got prenatally, pre-pregnancy, but starting with and then looking at preschool, development, pediatrics. Before you get to pediatrics, it's just within society that we need to implant this message. And wouldn't that be just fascinating if we could get out there and prevent and root cause? I find that fascinating. What you said is exactly the science we all need to know, which we sort of guessed at, but it's been researched and there in your book and studies. And what Sylvie's highlighted with the work in Essex, really fascinating, and what Synapse is doing, Ben, as well. And looking at those particular children with that, their gifts and skills and how they adapt to their preschool, and how limited school is. I've got teenagers and I can see how limited schooling is really for the personalities that you might be dealing with, and there's no adaptation there. But fascinating. Thank you so much. It really made me think more, challenging the brain cell.
Well, I can tell you, I've been so frustrated because this knowledge is out there. No, it's been it's in numerous reports to this government. If you look at the Children's Commissioner over the last few years and the reports that they have presented, it's all about early intervention and prevention and increasing input and resources to children. But it's not happening. And I couldn't understand it at all until I realized it's because children can't vote. So politicians don't focus their resources on people who can't vote for them. So I think those of us who understand that and who can vote really need to step up to advocate for children and early intervention, because it's a no-brainer. It's cost effective, but again, if a government were to do all the right things, you'll get the positive effects 10, 15, 20 years later when they may not be in power. And that's not how politicians think. So I think that is the catch-22 we caught in.
I think with the other comment is on the sex differences in between hypervigilance and sensory issues in girls, as opposed to more learning impairment, cognitive deficits. And I think there's some interesting literature out on microglia maturation, so immune cell maturation, having sex difference. So in terms of the immune cell in the brain that architects and sculpts the brain being different in boys and girls, I think that has a large reason why you see those differences are seen. The other aspect would be as a collection of interested researchers and professionals is to come up with I suppose a longitudinal research plan which we can demonstrate in our community into early interventions prenatally can have a big impact postnatally. And I think from today that would be really something to think about as a collective, to maybe as a steering group, to understand how we can demonstrate a kind of a feasibility or do some sort of pilot project which demonstrates early prenatal care and understanding and putting interventions in can have a big impact. Because at the moment, what we're facing with neurodevelopmental disorders in particular, we're getting about 350 referrals a month at the moment for children with additional needs, and that's going up every year. And some of those children have significant developmental problems, but a number of them are the ones you describe, Annie, the sensory processing, interoceptive difficulties, learning issues, and not being adjusted to the world that we live in and unable to learn. And every year of my career, that number is going up. So we need to find different ways of working, models of working. But that, no doubt, that lands a lot of that prenatally. Danielle, you have a hand up.
Yes, hi. I think that's very difficult research because it's such a mixed population you're dealing with, different conditions, different presentations, and simply different stressors at each of those individuals' lives that create anxiety. But to put it in a research context is very difficult because it's related to different things. So you can't really, you get such a mixed population. But I think one of the maybe slightly easier way to tackle this is to take the approach of more intensive programs for parents, starting early antenatally, in how and what does it mean having a baby and raising a baby, not just sort of being expected to raise a baby. You know, you're pregnant, you go to maternity, you deliver a baby, and then we have lovely health visitors that they do a little bit of that work, but I don't think there's enough of them to cover the need of a population that lacks the community validation of how it's supposed to look like being a good parent or meeting your baby's needs, and how do you respond to that in a way that's healthy. So ultimately it does come down to public health interventions, almost like it's like parenting hygiene. You know, this is something, and I think it starts probably even earlier with schools teaching children. I think some of the schools have started thinking a little bit of that. They put it on the mental health, but see, I think it's more of a mental hygiene. What do you do with yourself? How do you manage yourself? You know, how do you manage your emotions, which are normal? And then now you grow into a teenager, and what do you do then? And how do you expect it to function as an adult? Because at the moment, there's none of that. You're just sort of expected to cope with the world around you and manage. And some do better than others. For various reasons. Again, quite a heterogeneous type of population, like the world is really. But I think that's probably where we're going to be the most effective targeting people. For example, and I'm saying this because we do see, I'm part of a specialist service. We do a lot of interventions, and I'll speak a bit more about that from 4 to 5. Don't live early. Some of you, whoever can. But they've been showing that even any relationship that's helpful, you know, even a health visitor, for example, through the interventions they do, they can reach almost the same effect as people undergoing therapy in terms of outcome improvement. So it's not about as much about training and having very special, fancy, all sorts of things. Yes, those are needed for more complex situations, but overall, common things are common and struggles are common, and they are equally effective. So that's my take on things.
Thank you for those comments. The other thing I would add to that is the number of parents we're seeing who are neurodiverse, who have diagnoses of autism, ADHD, which are increasing, and the impact of those diagnoses on their parenting skills, but also the genetics for their children, which are increasing in a large population of adults with learning disability within tendering as well. Any other questions? No, I might take the opportunity to have a short break then, because I think we've been going nearly 2 hours. So I think if we reconvene at 3, and then it will be Professor Colin Martin and Dr. Catherine Fowler presenting on health and wellbeing and exercise related to the maternal mental health. So if we check in again at 3 o'clock, if there are no more questions. Great. Thanks. Oh, we got more hands up actually. No.
I've just put my thumb up.
Okay, great, thanks.
I did too.
Thank you, Ben. Cup of tea, right? Okay.
Okay, I think we're going to start again. Is Colin there? And Catherine?
I'm here, Ben.
Hi, yeah.
Fantastic. Good to see you.
Good to see you. And Catherine?
Oh, she's definitely here. She's been on the emails.
Yeah, I think we'll give her a minute then to get back.
Fantastic.
And I think Helen Jackson is presenting with you, isn't she, as well?
I believe she is actually. Yeah, she's going to be jumping in a moment, Ben. Thank you. Yes.
So we'll give it a minute, then I'll introduce you all. If that's okay.
Lovely.
Great. I think we're reaching 3, so we'll start. So the next talk is from Professor Colin Martin, Dr. Catherine Fowler, and Helen Jackson. And they're going to talk on perinatal exercise and its role for mental health, a project called PRAM. Just as a brief background, Professor Martin is Clinical Director of the Institute of Health and Wellbeing at the University of Suffolk, and Professor of Clinical Psychobiology and Applied Psychoneuroimmunology. And Dr. Fowler works at ESNEFT within their research department, and Helen Jackson is a perinatal mental health nurse. So over to you, Colin.
Great, thank you, Ben. I think actually Catherine was going to do the slides for this, incidentally, so she was going to do the first bit. So my bit was at the end, but I could probably kick off before she joins us, if that's okay.
Yeah, that would be great. If you can just give a perspective to your interest in this area.
Yeah, that would be great, because I was mindful actually about what you said at the beginning of the session about the possibilities of collaboration and so forth. So again, I may say, well, see Catherine's back, so maybe that's something that we can pick up on in a bit.
Shall we do that at the end? Actually, now Catherine's back. I've introduced you already, Catherine. If that's
sorry,
if that's okay.
It put me on hold for some reason.
Sorry
about that.
No worries. So I've introduced you yourself, Colin, and Helen. So I think you've got the slides to present. So I'll pass it over to you. Great.
I'll just quickly share them. And we're trying to keep this one as informal as possible. So if anyone wants to jump in, I know that you're probably on mute and can't get out of mute, but maybe put your hand up. Let's quickly share screen. Here we go. First of all, can everyone see that okay?
Yes.
Yes. Okay, brilliant. So you've introduced us all. That's great. So this afternoon, which is pretty great timing because everyone's looking forward to getting fit over the January period. I'll be talking about perinatal mental health and in particular the PRAM project. The PRAM project is exploring people's views on perinatal exercise and in particular focusing on mental health. All the presentations before this have been really, really interesting. And I've made a note about a few things such as social prescribing, inflammation, and it has got me thinking in terms of this project as well and perhaps ways this might go forward. So just to introduce the PRAM team. So we have Colin, Helen Jackson, myself and Steph Marlowe, who unfortunately can't be on the call. We also have a research midwife who's interested in being part of the project, so Victoria Gosnay, and also an obstetrician, so Dr. Garda, who would like to be part of the project. This is just a mix-up of lots of perinatal related words and certain things that maybe patients have mentioned within our patient and public involvement groups. So in terms of perinatal mental health services across the UK, by the way, I can't see anyone's hands or anything else, so Ben, you'll have to interrupt if anyone does have any questions during the talk. So perinatal mental health services were implemented in the UK in the NHS in 2018, which always surprises me because I always thought that there'd be, you know, services around before this. So this population have been underserved in the past. At ESNEF, there is actually a service that was implemented before this, which I will allow Helen and Jessica to mention when we get to that part of the presentation. But these services really focus on people with moderate to severe mental health needs, and they in the past went up to 1 year post birth, which has now moved up to 2 years in most places. But there is from the literature, perinatal mental health needs can be exacerbated up to 3 years. So it's just to point out that these mental health needs don't always get resolved within that 2 year period. So this is slightly updated in terms of the picture, in terms of when this was produced, but the actual numbers are still similar in terms of postpartum psychosis and the incidence of these mental health needs. So I've kept this in because it's quite a nice picture to show you the incidence in the general population in terms of perinatal mental health. So in terms of postpartum psychosis, approximately 2 people out of 1,000 maternities will develop postpartum psychosis. Then moving on to depression, it can be approximately 30 out of 1,000. And you can see from the mild to moderate depressive illness, it's drastically more. And in general, it's around 1 in 5 mothers that have a perinatal mental health diagnosis. And I just wanted to point out a little bit about OCD. So in terms of under-researched perinatal mental health conditions. So in terms of obsessive compulsive disorder, most people are aware of hand washing, but they may not be aware that perinatal OCD is more likely. So OCD generally is more likely during the pregnancy or after having a baby. And it's also prevalent in the dads and the mums equally, and it could be up to 9% of people having perinatal OCD during that period. And I just wanted to highlight what mothers have said that it feels like. They've said that it feels like a loss in terms of they lost an important time in their life due to OCD. And a member of our patient public involvement group, for anyone that doesn't know about patient public involvement, that's when we involve people that have, for example, if we did a cancer study, we'd involve people with cancer into the design of a study, making sure that we involve them early on to get their views. So with our perinatal PPI group, we have had people that have had mental health needs in the past, and one member said that they didn't feel able to put their child in the car seat. They didn't feel comfortable. Their obsessive thoughts were impacting that in their daily life. So it really does make a difference to their day-to-day life. Sorry. Just seeing why it won't move to the next one. Oh, there we go. Has everyone got perinatal period on there? Yeah. So I understand that these are not pictures of pregnant ladies on the bike. So my background is I'm a clinical exercise physiologist, and in the past I was trying to get people fit for surgery. So a bit like pregnancy being a stressor, surgery was a stressor. And with our exercise testing, we wouldn't tend to test anyone that's pregnant. particularly in the latter stages. So this just gives an idea of a stress test here. So we've got a gentleman there, and I've got permission to use this photo, and we've got Dermot O'Leary there with Professor Craig White. And it's just to explain, like with a stress test, you're really stressing the heart, the lungs, and that's what the perinatal period has been likened to, a stress test for both the parents. And just to explain that there are many stressors, which I'm sure most of us are aware of, like the hormones, the concern maybe about physical or mental health. Maybe they've got a diagnosis of gestational diabetes, maybe after having the child, or perhaps during pregnancy, depending on what symptoms they've got. There might be sleep deprivation. I certainly know that I had a child, my child didn't sleep for 1.5 years, so that certainly put me through my paces. And lack of support, previous birth experience, as mentioned in the previous presentation, the birth experience might impact how they relate to having a baby, their expectations, childhood experiences, also mentioned in previous presentations, and lastly, pandemic, which obviously is usually very unlikely, but unfortunately has happened. And as Sylvia said, the impact of the pandemic on mothers has been great. So I'm not sure if Helen, are you there? Helen Jackson? Is Helen there? No. Jessica?
Hi.
Hi. So I'll just quickly, so Jessica, I spoke to a minute ago. I saw that she was on this call actually, and Jessica's one of our perinatal mental health specialist midwives at ESNEFT, and I just wanted to see if she would kindly talk about the service that we do at ESNEFT, because it is quite unique in terms of there aren't many NHS trusts that do a service, particularly for those with low to moderate mental health needs. So Jessica will explain about that service, if that's okay.
Yeah, sure. So I came into post about 2.5, 3 years ago, just after I had my baby and came back from mat leave, and we really needed to look at the women that were kind of GP led on a little bit of medication, but kind of needed a little bit of signposting and needed to be told where to go, or a little bit more support and TLC, or possibly trauma informed birth plans, but weren't moderate to severe enough to come under the team. So when I came into post, we set up a clinic with Helen that she'd piloted in the West already at West Suffolk, and came over, and we started it in June 2020, I want to say. No, a little bit later. Anyway, so we started it, and basically we get referrals from the community midwives if they're concerned about the women at booking, or we get referrals from the GPs that have gone through to the team via Emotional Wellbeing Hub and AAT referrals, who then will pass them to the perinatal team, and they will say, well, we don't feel this woman's moderate to severe, but we feel like if maybe we could signpost her and see her in the clinic and give her some more advice and actually see her face to face, she'll felt heard, she'll felt listened, and then we can actually stop and prevent what might get worse at 40 weeks, at 8 weeks. So that's what we kind of do. We hold it every Friday at Ipswich, and generally pretty much every Friday we see 9 women for about an hour each time, and it is pretty much full every week. And as I say, the referrals from community midwives who've got concerns for their women, or from GPs as well, that they just don't fit the criteria of the moderate to severe but need some further investigation. And the outcomes really, Helen, I guess, was probably going to present them, but the outcomes have been really, really promising, that the women have felt heard, they felt the signposting was correct, they felt that it has prevented further need to access GP or further secondary services in the pregnancy or afterwards, because they felt like it's been nipped in the bud early on, which is the aim of what we're trying to do.
Thank you so much, Jessica. Thank you. And I'm not sure if Helen can join. I think I know that it's particularly clinically busy today, but if she does join, hopefully she'll be able to run through the local perinatal mental health services. But in terms of what Helen does, she set up the perinatal mental health service, which runs at Bury and Ipswich, and so it's Norfolk and Suffolk as well. And that's for people with moderate to severe perinatal mental health needs. That's Helen there. So in terms of how our PRAM project formed, and it's not launched yet, but I will run through it. So just to give you an overview, so with my background being perioperative exercise, got a great interest in exercise and the benefits that it can bring. And a lot of the people that work in perioperative exercise think of it as being a medicine almost, as in a natural way. A lot of the consultants in Southampton are advocates of it. So in terms of my pregnancy experience, I felt that I wasn't guided in terms of exercise during any antenatal classes or any pregnancy related class at all. But luckily I kind of knew what types of exercise I could do and continued with that. But also I've had other people mention to me that they had a similar experience. So I had been pondering an exercise related research idea and met with Colin, Professor Colin Martin, and went for a coffee. And it was a bit like a dragon's den. I thought, okay, do I tell him my idea? So I just went ahead, told him my research idea, and he thought it was okay. So I followed this up with Helen Jackson, who I knew at NSFT. So Helen, the perinatal mental health nurse, and she was keen with the idea too. And we went for funding. So UEA released some funding. So for the health and social care partners, we were awarded some funding to do this project. Sorry, it's just been a bit slow with turning to the next slide. So in terms of perinatal exercise guidelines, generally they're very similar to the general population, although it mentions not to bump the bump, so contact sport, that type of thing. Also not to do vigorous activities. This is the Department of Health guidelines, and these are also the same as the American College of Sports Medicine. Their guidelines are the same, so 150 minutes of moderate exercise each week. And in terms of perinatal exercise, that's exercise during pregnancy and afterwards. In terms of, well, first of all, going back a step to pregnancy specifically, there's been evidence to show that it can reduce your risk of gestational diabetes, urinary incontinence, also cesarean section. So, and these are just some of the studies. I haven't included all the studies that list these beneficial effects. And also in terms of mental health, unfortunately, most of the studies in the past have focused on postnatal depression. But from these studies, there are a lot of studies that have shown a beneficial effect on depression rates. However, there was a study I wanted to highlight, which is called the Pamela study, which looked at a 16-week exercise program. And they found that it didn't alter postnatal depression. However, there was very poor compliance. So what that means is that basically 40% of the group didn't do the full exercise program. They have missed sessions, and it could be related to the depression. So when people are depressed, obviously not as motivated, don't feel as motivated to do exercise. That's in the general population. So it seems fitting that it'd be similar in the perinatal setting too. So it just highlights that it's really important to explore what the barriers are, the facilitators are to prenatal exercise, to find out what might help people exercise and also what might hinder it. From the literature, there are very few studies on OCD, anxiety, other types of mental health needs. In terms of qualitative studies, so studies where people were asking what the barriers were or the facilitators to exercise in general, regardless of mental health need, it was just general pregnancy population. The main reasons from the literature are as follows here. So fatigue, time, they may have felt like they didn't have time to do exercise, pregnancy-related illness, so the nausea was mentioned quite a lot, tiredness, which obviously links with fatigue, safety, so some people felt it wasn't safe to do exercise, they were concerned about the baby, were also knowledge of recommendations in terms of exercise recommendations, they weren't sure what was safe to do. And I do apologise, got a bit of a cold, so I'm just quickly have a cough, 1 second. Sorry about that. And motivation. So the motivation to actually do exercise during pregnancy, that was one of the barriers too. And these are the main ones that I found. Also just wanted to highlight a study in 2014, so I appreciate it's nearly 10 years old, but it just highlights the general consensus in terms of what is happening during pregnancy related to exercise. So just under 50% of women reduce their physical activity during pregnancy, and only 7% increase their physical activity. And unsurprisingly, those expectant parents that felt concerned about safety in terms of their child, their unborn baby, they partook in less exercise. So why do you want to look at explore people's views on exercise in pregnancy? First of all, there's a gap in the literature. There have not been many studies in terms of looking at what people's thoughts are on exercise during pregnancy, specifically to mental health. Also, we feel that perhaps it might be a good tool, a preventative tool to either prevent mental health needs or improve mental health needs during the perinatal period. I liken it to the perioperative pathway where we have before the surgery and after surgery. That's a great time to kind of improve people's health, specifically their fitness levels, and this has knock-on effects generally on well-being. And we hope that this study will hopefully, from the views of people, will help to guide a exercise program to co-produce one. But most importantly, this is about the people, so the person that's pregnant, to ensure that we can explore what would help them and what would hinder them from exercising, but also for their children, because as we've heard in other presentations, but also I didn't mention earlier on that actually prenatal stress can, affect bond and can increase risk of things like ADHD. And it's mainly about that bond. So perhaps maybe even exercise as a family might help to improve that bond. So our aim is, we're not doing an exercise program at all. This obviously that's my future thoughts, hopefully, depending on what the results are of this study. We aim to explore what people's views are on exercise, specifically expectant mothers and healthcare professionals within the perinatal period. And I just wanted to go through patient public involvement in terms of what we've done through this project, well, starting the design of the project. So we advertised it far and wide, and for people that were very interested in helping with the project in terms of giving their views, all who had perinatal mental health needs across the UK. So we put it out to people across the UK, also around Esneft, and they input into the study design, so how we made the information sheet. So for example, initially we had a bit about what the risk of certain mental health needs are in terms of postnatal. So we've removed part of it where we had, we mentioned like psychosis. And so we made sure we removed that so that expectant parents weren't having enough of worry as well, something that is so rare that we didn't want to add to their anxieties. We also have changed the information sheet, so put pictures in there of people that are pregnant, or just also the team, to make it a bit friendlier terms of that there's people in the research team that are doing this research, make it more friendly. And we've also designed our topic guide. So I'll go on to the topic guide in a bit, but basically it's how we ask questions to individuals, what questions we ask. So how we changed it was that the people in the patient public involvement group wanted to know more about what people's expectations were of pregnancy generally, and of exercise. Also exploring what healthcare professionals suggested to people during the antenatal period and what they'd suggested about exercise. They also wanted to find out from participants what they felt was an acceptable level of exercise, because it might be that my thoughts on my acceptable level of exercise would not be similar to someone else. So we wanted to quantify that. And they also mentioned that perhaps, so one of them was from a military background, and they mentioned that perhaps it'd be good to explore that route a bit further in terms of trying to get people involved from the military areas, so underserved groups, and being Esneft is a very military-based setting, so we've got Watersham up the road in Ipswich Way, and then in Colchester we've got our Colchester Barracks, which actually my background is I'm a military child, so it took the PPI group to raise this, and whereas I should have probably thought of that myself in terms of involving the military groups, because military personnel generally, their mental health needs are double the population, general population. In terms of patient public involvement, we have standards for our patient public involvement, and how we try to meet these standards. We're ensuring that the advertisement for patients into our patient public involvement was clear. We removed any medical jargon, so tried to stay away from perinatal, made it more pregnancy or after having a child, that type of thing. Also, we have involved our patient public involvement group in how we've shaped our patient-facing documents, our information sheets, to make sure that when we come to the research study that it will be very clear. And we also tried to reach people at a very early stage in terms of patient public involvement before we'd written a whole protocol. We tried to get them as early as possible to shape the research. Here's just a few quotes really to show the people behind this. So one striking one was one lady said, they said that as I was of sound mind, that I couldn't have postnatal depression. Just please note that these are actually people away from the local region, but I said this must have been about 10 years ago, she said, and it had dramatically impacted her. Also, people said that I felt that I had to be strong as a military folk are, yet every day I could feel that I wasn't myself. So she decided not to seek help straight away. So it's almost like she had to cut down the barriers. Other people have said lockdown affected services, and I had an early discharge from perinatal service. And someone said there's still a fear that exercising or jumping will harm the baby during pregnancy, which I think I wouldn't be surprised if a lot of people still think that. So in terms of our research project, so we've done our patient public involvement, which will continue throughout the project, and hopefully afterwards to wherever this study may take us. The actual study will involve expectant mothers, so we'll be doing in-depth interviews with 10 to 20 expectant mothers until with the themes, so basically the data saturates, so we don't get any more themes from our analysis. I just wanted to confirm that I won't be doing any interviews, so as chief investigator, and also with my background being exercise related, it's really important that I'm independent to these interviews and to the analysis to ensure there's no bias. And we'll also be doing survey with healthcare professionals, so anyone within the perinatal field, to see what their thoughts are on exercise during pregnancy. And in terms of the in-depth interviews, we're mainly focusing on beliefs such as behavioural, normative and control beliefs that are from the theory of planned behaviour. But we're also, since we're not about to start just yet, we're applying for ethical approval soon. We're also going to explore the COMBI application to the topic guide. So this is a different theory, and it would just add more to the topic guide in terms of exploring what people's stage of behaviour is, and explore more of the factors here. So regulation, restrictions, environment. And with theory of planned behaviour, I just want to give some examples, because mentioning normative beliefs and control beliefs, behavioural beliefs, you might not be familiar with those. So, for example, a behavioural belief, it's what the person's belief is on the outcome of exercise. So if someone thinks, well, if I exercise, it's going to harm the baby, then they won't be as likely to exercise. So it might be a positive or a negative attitude towards exercise. A normative belief, so it's kind of what you think your healthcare professional expects of you in terms of exercising. It might be what your partner thinks of exercise, or whoever's your social network. And also control beliefs are your views on what might facilitate or limit exercise. And that could be what would prevent you from exercising during pregnancy. In terms of the healthcare professional survey, I really struggled to find any literature where they had a survey surrounding what healthcare professionals' thoughts were on exercise. But I found this article, which was done in a GP surgery, and I contacted them and asked if I could borrow their survey with permission, and they said yes. So this is the survey that I have adjusted slightly so that it's perinatal rather than GP practice. So this survey is looking at health promotion. What do people agree that health promotion is part of their role, or do they disagree? And also physical activity advice. Do they give people advice? What do patients expect? Is there a lack of available education? These are all questions from the article before. And in terms of our next steps, so we have to go through Health Research Authority and Research Ethics Committee approvals, hoping the end of January. So if anyone has any thoughts whilst I've been speaking, where they think, oh, actually, have you thought about this? Have you thought about that? Please do let me know. We're always open to, constructive criticism or highlighting some changes that we can make. After we get approval, hopefully we can start recruiting staff and people with mental health needs, and we'll continue our patient and public involvement. Also a strong part of this project, so even though we've got funding to do this research part, I also mentioned in the application that we wanted to set up a patient and public involvement group for fathers or father figures, because there's been so much literature to explain that dads also suffer with perinatal mental health needs. So we will be setting that PPI group up soon to see what their thoughts are around future perinatal research, and explore their thoughts on what they would perhaps want to be researched around this area. And it's really important to get their thoughts first before diving into any research, because we need to involve them straight away and see whether it's even something that they would be interested in. And just before I go on to Colin, yeah, my my blue sky thinking is, hopefully in the future we could co-produce an exercise program that would be developed with both parents, father figures, partners, to do a socially developed exercise class where people would reap many benefits. But obviously this is just my blue sky thinking, and who knows what happened, but we'll just start with this PRAM project first and see what people's thoughts are. So, Colin, over to you.
Thank you very much, Catherine. That was brilliant, as always. Wonderful presentation of PRAM study. That's fantastic. And big thanks to Catherine as well, actually, for in terms of being the principal investigator on this, who's really taken the lead and pulled the whole thing together. One of the things I really want to talk about is actually what Ben raised at the start of the session was about collaboration and further collaboration across our network, and particularly in the area of perinatal well-being. That's particularly important for us, both at the university and at the trust. So just by way of a bit of background, I'll just show you a couple of books. The perinatal mental health book was my book. That came out nearly about 10 years ago, and that was really before perinatal mental health rose in the ascendancy. So we've been doing lots of work on perinatal mental health for many years now. And what I really want to emphasise is the focus of our work has had a very interdisciplinary focus, but not only that, a very psychobiological focus as well. So we're very interested in the role of physiology in mental health problems during the perinatal period in particular. And again, that's really kind of circumscribed our work in the field. And that's why the study like the PRAM study is really important to us as well, because it fits in not only as a standalone study, but part of our theme of integrative perinatal well-being work, including mental well-being and also physical well-being as well. And again, within that kind of conceptualization, the other book just to highlight, which came out last week, is on CBT. In actual fact, published 2 books last week on cognitive behavior therapy. This one is one that focuses on very specific groups. So there's lots of stuff in there on pregnancy. The other one's much more psychiatrically focused, actually, but this one's much more around pregnancy, adolescence, and very specific groups. And again, our research has gone down this route of going on from postnatal depression, generalized anxiety disorder, postpartum PTSD, tocophobia, and so forth, but very much applied. And that's what we're really interested in, is the idea that the research work that we do is very much practically applied with a short lead-in time in terms of improving service users and patients' well-being. To give an example of that, while I was working previously in Hull, whilst I have quite a strong connection with the perinatal mental health team up there, we were one of the first trusts to implement a tocophobia pathway between maternity services, primary care, and our perinatal mental health team. And again, what's very exciting about the perinatal service that Catherine and Helen were talking about in terms of the trust is perinatal mental health teams are very different across the country. And that's how diffuse the situation actually is. So, for example, service I worked in Hull, perinatal mental health team that I was part of, we would be the more extreme, the more severe conditions, so severe postnatal depression, severe PTSD, personality disorder, we would see, whereas the less severe would be going to IAP services. Now, there are other services across the country as well, for example, where the perinatal mental health team wouldn't see personality disorder. They would go to a dedicated PD team. So again, one of the reasons for that diffuseness is actually about the diffuseness within the evidence base. So it's very important to start bringing this together in a robust and systematic way. And that's certainly the approach that we're wanting to take. Now, just to share with you some of the work we've done to give an illustration of that. Again, one of the very, very early studies I was involved in was a randomized control trial 20 years ago, so when dinosaurs still roamed the earth. And this was a study that was looking at pre-labour rupture of membranes at term, which at the time was very conservatively managed and very inconvenient to women, actually, who had a PROM at term. And for those who are old enough to remember, is what's really interesting is actually prom at term now is no longer conservatively managed. And the first NICE guidelines that come out, I think they were the very first NICE guidelines come out in terms of maternity, said there's 2 studies that say keeping women in hospital for prom at term is a waste of time. One big American study and one small UK study, and in actual fact it was our study. What was really interesting about that, though, is actually, although it demonstrated it was safe to send women home with prom at term, there was a psychological difference between the groups, between looking at the intervention, which was staying in hospital or going home. And again, that really fostered our interest in the relationship between the psychological component in terms of maternal well-being and maternal mental health, and the physiological aspects of care as well, more broadly. More recently, and again, it's probably the work I'm more known for in the perinatal field, is in terms of birth experience. And a few years ago, Professor Caroline Hollins-Martin and I, we developed an instrument called the Birth Satisfaction Scale Revised. It's actually become a gold standard. It's a globally endorsed birth outcome measure in the International Confederation of Health Outcomes and Measurement Pregnancy and Childbirth Standard Set. So it's sort of globally endorsed measure for looking at birth experience. As far as we know at the moment, because we keep a record of studies where it's being used in over 270 studies worldwide, in 58 countries worldwide. So we're doing a lot of work on that, looking at birth experience. And what's really interesting about that as well is we've been doing a lot of work on intervention deliveries compared to, for example, unassisted vaginal deliveries, instrument deliveries, assisted deliveries, emergency C-section compared to elective C-section, and looking at very significant differences in birth experiences as a result of interventions, which impact very significantly in terms of perinatal well-being. And indeed, in terms of the perinatal mental health service that I was part of, we would see women actually coming into our service as a function of their birth experiences. So that's really quite important, not but in terms of the perceived trauma of the birth, but also the perceived experience of it, but also that relationship between the actual intervention itself. So I've done lots of work on that, and I'm involved in many studies worldwide in that area. And again, in terms of some of the underlying physiology, we're very interested in that. I had a book out just a couple of years ago, in terms of looking at the microbiome and mental health. And you may or may not be surprised to know that a big aspect of that particular book, and a big area of work that's developing in terms of microbiota, is in terms of pregnancy and childbirth. And you will be, for those who aren't particularly aware of the area, no reason why it should be, the microbiota profile of babies, when you compare a woman who's delivered in terms of vaginal delivery, whether that's assisted or not, compared to a cesarean section, is vast. Yeah, it's a completely different microbiota profile, and that's really interesting to us. So we're really interested in that in terms of its relationship to later psychological and neurological development in terms of the baby, and also mother's well-being as well. So again, we're really interested in that. We're interested in dads as well, which is really important area. We've been actually using the BSSR to look at dads. We're developing a version for dads as well, and for partners, partner version for that particular measure. So lots of work there, lots of work on tocophobia, lots of work on postpartum PTSD, some of that very theoretically important as well in terms of the nature of postpartum PTSD, and is it different to, how can I say, normal PTSD? In actual fact, we're very excited about a study we've just finished in Sweden that we've actually just submitted for publication, and we're in a race at the moment with another international group regarding our findings, which actually tend to suggest to us that postpartum PTSD might be quintessentially different to normal PTSD. And that's really important because that actually has some significant clinical implications in terms of our therapeutic and approaches to postpartum PTSD, because the actual interventions now are the same for normal PTSD. And so that's quite important work as well. So again, we're really excited to actually be in the Synapse network as well anyway. Neuro, funnily enough, I was speaking to Ben about this only a couple of weeks ago. The main stuff I do is neuro. It's just almost serendipitously that I've got into perinatal, but it's a very, very big part of the work that I do. But we're very interested in some of the neuro aspects as well, in particular, in terms of perinatal, particularly in psychiatry, neuropsychiatry, neuropsychology, and neurobiology as well as the more general kind of psychobiological work as well. And again, just as a background to that, I've done quite a lot of work in HIV and pregnancy, interested in that as well, quite a lot of work in the menstrual cycle. Relating to more general perinatal mental health conditions, I should probably mention as well, and that is why we try to work to a framework which is integrative rather than exclusive. We've done quite a lot of work in the past on schizophrenia, but one of our working models of psychosis is actually based around postpartum psychosis. So we're really interested in pubertal psychosis, postpartum psychosis. We've done some small pilot work that's been really interesting about the idea about some qualitative work about women developing unusual thoughts. And we were very surprised to see that we can actually see almost a signature late in the third trimester of pregnancy in terms of the development of an architecture of unusual thoughts in women, except for one small group, believe it or not, women who are having assisted reproductive technologies in terms of getting pregnant, having difficulties getting pregnant, and when they do get pregnant, and they seem to develop some unusual thoughts and unusual thinking patterns earlier on. And this was a group of women we looked at who had pubertal psychosis, and then we've actually done some interviews to look at the natural evolution or their historical narrative about the development of their disorder. So we're really interested in that as well. So again, I'm involved in a big European group, which is a cost action, which was on peripartum depression. So we're really interested about this idea about, postnatal depression. How different is this to general depression and the relationship to generalized anxiety disorder, that kind of thing. So again, there's a lot of work in that field we're involved in as well, and always very excited to be working with my best friend, who is Dr. Catherine Fowler. So I think that's all I've got to say about it, Catherine.
Thank you, Colin, and thank you for all your mentoring you've done throughout the past 6 months, should I say, and yeah, your expertise in perinatal mental health is amazing. So I'd just like to ask if first of all, if there's any questions, but also to give some thank yous to our patient and public involvement group for their feedback, and also for the funding from UEA Health and Social Care Partners, because it's just fantastic that they were, very interested in this research idea, and to give us this opportunity will help us to perhaps explore perinatal mental health interventions and take this forward. I also wanted to thank Dr. Ben Marlow for inviting us to talk, and I'm sorry that Helen wasn't able to make it, but as we know, the perinatal mental health.
Here.
Oh, hi, Helen. Did you want to say anything quickly before we end the call? Because you're central to this for setting up perinatal mental health services locally, and being on the ground helping these ladies and partners as well. I know the extent.
Yeah.
So I'd love to hear from Helen. I'll move to the slide.
I will be very brief, as I'm aware of the time. Apologies, I couldn't get in and then my speaker wouldn't work. Tech. Yeah, I guess for us as a service that is supporting women along the whole of the sort of mild, moderate, severe pathway, thinking about different interventions that will help them as part of their mental well-being, which then has an impact on their, you know, parenting and relationship with their infant, can only be a good thing. You know, not everybody wants to do exercise, not everyone wants to do talking therapy, not everyone wants to, you know, fit in the same sort of, you know, square hole, as it were. Yeah, I just think we're really, you know, I've worked in mental health in 25 years, and there's never been such a sort of good spotlight on parents and their infants in all the years I've worked in the NHS. And I think, you know, by looking at every option for people is good, and have a more holistic approach, you know, I think is really important. Yeah, I think, you know, the Suffolk perinatal team will have been in post 6 years this year, and we've just grown from 2 nurses to 20 odd people now in the team of, you know, real good psychological base, peer workers, the development of the maternal mental health service. So looking at, you know, loss, trauma, you know, so many different sort of aspects to what can impact on a person's journey within that perinatal you know, timeline, and the fact that, you know, for some women we'll be going up to 2 years postnatally as part of the long NHS long-term plan. And so I guess, you know, something I'm already thinking about, Catherine, as you were talking, is postnatal options for parents, you know, as well as the antenatal, if we're thinking about their recovery. So I think that would be a really exciting thing to think about after this sort of project. And yeah, happy to help recruit women to this, and happy for our service to be part of this. Yeah, excited to see the results.
Thank you so much, Helen, and thank you for your insight into this project and helping with the protocol. Helen's been fantastic in terms of reviewing the protocol, making sure that, and also being part of the bid as well, making sure that that we get to the right people in terms of we can recruit people with perinatal mental health needs, and even the simplest thing that you wouldn't think of, such as, of course, you won't ask someone with an eating disorder about their exercise levels. Even that, you don't think of it straight away, but when Helen reviewed the protocol, you know, that it's something you don't think of or pick up straight away. And I know it's very clear that you wouldn't, but yeah, so it's just been vital. So any questions?
Many thanks, all the team. That was a really great talk and initiative. I think it kind of integrates the first 2 talks really quite nicely, talking about mental health, the biology and underpinnings of challenges prenatally, and an intervention, which will be the exercise, which is very holistic, addressing both physical and mental health challenges. And again, I think it's about collaborating. So thinking about the outcomes that Sylvia used at Baby Lab to measure mental health outcomes, but also from our perspective as paediatrician is looking at follow-up for the children longer term. So the intervention, which is the potentially the physical health and the exercise, and then following them up longitudinally with their children postnatally, would be really interesting for us. So really good project. Any questions for anyone else? How many families are you expecting to recruit?
It would be between 10 and 20 roughly. Okay. So because with any qualitative study, it's until the data saturates, so until you get no more themes.
Okay. Annie, you've got your hand up.
Again, fascinating. Thank you so much, team. Helen, we've met, and really good to see that you're involved in all of this. This is fascinating. There's a few thoughts. Gosh, I don't know where to start. But anyway, thank you, Catherine, Professor Martin, Helen and Jessica. Catherine, on the exercise front, in primary care, we all know that exercise affects your mental health. I don't think we translate that in the perinatal period very well at all. So lots of education needed there. Probably you know, and Professor Martin knows, that there are NHS national GP champions for exercise. So we've got Dr. Thorogood locally. We actually had a lifestyle medicine conference run by Equip in Essex, the first ever. Ben, I couldn't believe it when this was advertised, but we had Dr. Thorogood speaking on exercise. This can easily be translated into how you sleep, eat, move and relax in pregnancy, as in any consultation in primary care. So that's the way forward. I'm sure networking with her would be helpful, Catherine, and primary care. But actually, we should all be exercise champions. I'm your GP spotlight champion for perinatal mental health, but of course, lifestyle fits into all of that. So that should be a message we're getting out to primary care, most certainly. I'd be interested to see how you fit in with the IAP services. I'm happy to connect you with our IAPT in North East Essex, Kerry Coker, Gareth, in the Colchester base anyway, because what you say needs to be implanted in the IAP service, and I'm sure they're doing it, but exercise, lifestyle's all there. Helen, you're probably doing that in Suffolk, but I'm wondering about North East Essex, and happy to connect you on that front. Gosh, Professor Martin, everything you're talking about and research is so relevant to perinatal mental health, primary care, the whole caboodle, really, isn't it? It's fascinating what you're doing. I'm sure, Ben, we could all link in somehow with that work. I mean, that's just mind-blowing that you're part of the studies that we're implementing in practice. I'm sure Daniela on the perinatal mental health side, as our consultant, will have more to say on that. But from a GP perspective, that's fascinating, and look forward to working with you as a perinatal lead, but also as a GP, because this affects all impacts my patients and their well-being. So this is great. So thank you very much. And Jessica, it would be great to link in with you on the ESNEF Colchester front, and again with our IAP service. What are we doing to support, and how we're integrating that lifestyle in? Yeah, thank you so much. Really fascinating. Lots to learn. Future collaboration.
Thank you so much. Thank you.
Great. And I suppose the focus of today is collaborating, isn't it? And learning from each other and being able to link in. So I think there are potentially some really good collaborations to starting. I've been neglecting the meeting chat. So I just wanted to update that really from what I've been reading. Where I missed it now. So Jo Harrison from Essex Family Forum, this is linking back to one of the previous talks, talking about her own experiences with ADHD and neurodiversity in children. So thank you for that, Jo. And Simon Heary commenting on the agreeing with the value of health visiting from others, but the problem is Suffolk Council has halved the number of health visitors in Suffolk, so can't do as much as they used to. So an example of how services are being affected by funding and the impact they're having on families generally. Which we've discussed already. Trying to do more with less, which is another comment that Daniela Hooper also raised. Okay. Any other questions for the I'm going to call you the Pram team? And thank you for sharing your books, Colin, and your experience writing those. I'll have a look at those.
Yes, I will too, Colin. Thank you very much.
Thank you, and
thank you to the Pram team as well. That's yeah, thank you for all the hard work, and it's fascinating. Yeah.
Okay, so I think we've got our last speaker. I think Daniela Hooper was going to talk with Alan Alty, but sadly Alan isn't going to be with us today. And Daniela is going to conclude the talk. So if I pass, I don't know if Daniela is on the call, if you wouldn't mind introducing yourself and the type and what you'd like to talk about today. Thank you very much for speaking.
Thank you. I mean, I'm Dr. Hooper. I am the perinatal psychiatrist for Northeast Essex. I have been here since November 2021. Prior to that, I worked in South Essex for a couple of years, also for the perinatal team. It is my first consultant post, so and I think I've been very lucky to start my career in psychiatry in such a wonderful environment. My talk is very simple. It just unfortunately, Ellen is not here. Ellen is our psychology lead for Essex perinatal mental health team, and also for Together with Baby, which is our parenting for psychotherapy service. I didn't quite know what to say, but what I'm going to be focused on is what the perinatal team, perinatal mental health team is, what sort of things we're doing. Some of the things I'll talk about, you probably have heard from others. So quite a practical session, and very quite brief. But any questions at the end of it, or even in during the presentation, I'm happy to take. Although I won't be seeing you, or any hands. So Ben, if you want to pick on those as I'm going to share the presentation, let me know. Is that all right? So let me share the presentation for now. Just a second. Okay, all right. This is the agenda, you all know it. Okay, just a bit about the Essex perinatal landscape, which is in a way similar to Suffolk. We've been here for, again, good 6-7 years now. We've grown as a service from one doctor across the whole patch to now almost 5 doctors, and across the whole of Essex, really. We're a massive geographical area, actually. We're split in 5 hubs, which are sort of around the maternity hospitals we cover. So these are all the maternity covers, and this is our sort of footprint for Essex perinatal mental health services. And each hub has a team of clinical lead psychiatrists, perinatal practitioner, which are nurses, social workers, psychologists, therapists, OTs, support workers, nursery nurses, and social workers. So they all bring their contribution. The team roles are defined by the service specifications that have come from the work with NHS England, and from what's needed for the long-term plan. And talking about the long-term plan, we know that there are 20% mental health difficulties in pregnancy, 1 in 5, and our business is to see about 10% of those. We started off with 3.5% we were meant to see, and year on year that target has increased. Now that leaves 10%. That is not our core business, and that has to be managed by universal services and primary care. I tried to put a little bit of a picture here to show you the stepped care model across the services and across all the agencies. And as you can see, some of them are seen in primary care, but that doesn't mean they don't have access to all the other agency input, such as social care, voluntary sector. Obviously, everyone has to see maternity during pregnancy and health visiting afterwards. They're different. Each of these agencies have their own stepped care approach to interventions that they can offer. So it's all very complex, actually. And we are sort of sitting, I mean, we're supposed to see moderate to severe, but of course, that's very difficult to establish that threshold. So we did struggle with knowing where to draw the lines, because at the end of the day you have a woman in distress, and a woman that needs help when they are referred to your team. So that's why we developed a part of our team has an assessment pathway and then an intervention pathway as well for the more severe and the ones for the assessment pathway. We try to point people and bring other type of support for them, whether that's primary care or extra support from universal care services. We try to bring